Welcome to the Breaking Pain Podcast. I'm Dr. Zamir Parani, an interventional pain specialist in Toronto, Ontario. This is where we break down pain one conversation at a time, because your pain relief starts with your understanding. Today we're talking about back pain. Specifically, when is surgery the right choice for you? I have Dr. Colby Oitment, an esteemed colleague of mine and a spine surgeon also in Toronto, Ontario. He has worked on a wide variety of patients with various degrees of complexity. I'm very grateful that he's bringing his expertise to us today. If you have been struggling with back pain and you want to know more about if surgery is potentially beneficial for you, this episode's for you. Welcome, Dr. Colby Oitment.
Thanks, Sam.
So, Dr. Oitment, I'm very, very grateful that you're here with us today. Hopefully you can break down some of the myths for some of our listeners today. So, we know that chronic pain is defined as pain that persists for more than 3 months. It can happen in any part of your body. And when pain becomes chronic, we know that it can have various effects on patients, including mental health issues, depression, anxiety, can lead to job losses, and can cause a lot of stress for not only the patient, but also the people that are involved in the patient's life. So back surgery, it's something that can be quite significant for a patient. And a lot of patients ask me in my practice is back surgery the right choice for me? And so hopefully we can talk about some of the common conditions in low back pain and how you stratify patients in preparing them for surgery or preparing them for other interventions other than surgery or non-surgical options, we say. So I'm going to start with some of the patients that I've actually sent you to your surgical practice. And one of the patients, I'm sure you remember her, a young 35-year-old female, very, very active, does yoga, Pilates, is part of a running club, has not a single medical comorbidity. When I say medical comorbidity, I mean to say she's just an extremely healthy person. She unfortunately had a herniated disc, and she had extreme pain that went down to her leg, down to her toe. And it was in the L5 distribution. I did a few epidurals for her, which gave her some relief, but only about 50% relief. And she was kind of in that period of greater than 3 months of pain, getting very, very frustrated. She did all the conservative measures like physiotherapy. She had an MRI finding, so we looked at her image together and we saw that she had an extremely, tight pinched area there. She did respond to epidurals, but not to a degree that was acceptable to her. And it was causing her extreme anxiety and stress. So what would you say about that patient?
So thanks. What you've described sounds like a very good candidate for surgery. You're talking about a young, healthy person with one area of the spine, not many, but one area that's problematic, and symptoms that match what you'd expect from that area, and the sides and everything match. So, and they've also had a reasonable response to interventional techniques. Like you've done some injections, they did provide some relief, but it wasn't enough. And you've given the body enough time to try to heal itself. But unfortunately, sounds like she was part of that smaller group where it didn't heal spontaneously. And so what you've described, that is the ideal candidate for one type of surgery, maybe a decompression or one of our methods of freeing up space for that nerve.
So what exactly is a decompression? Could you just show our viewers on this model?
Of course,
here?
yeah. This model's a little small. It might be hard to see on the camera, but you have.
I have a better one for you, Dr.
Okay,
Raymond.
sure. So what you're talking about here, for example, we can see sort of the bones at the back. And here in this model, for example, they've highlighted a red herniated disc at L3-4. This would be, and it's pressing on that nerve there. So I don't know if you can see that in the camera, but essentially if we wanted to free up this area, we take off a little bit of bone just to visualize the nerve root underneath. And we go after that little piece of disc. We don't cut out the whole disc. We don't cut out the entire joint at the back. We just free up enough space. We essentially make a little hole in the spine in a very precise area to give the nerve root underneath space. And that's the whole goal of that, the type of surgery we're talking about there, just a little microdiscectomy.
So, Dr. Oitment, thank you very much for that, very comprehensive assessment of the patient. Now, I'm also, as you know, an anesthesiologist. That's another cap that I wear. And I take great pride in preparing patients for surgery. As a surgeon, you obviously have to take care of the patients after their surgery, and you have to prepare them for the rehabilitation and the physiotherapy. So one of the P's of chronic pain management. And how do you have that discussion with patients, and how does that change your decision whether to operate on a patient?
So I think firstly, in terms of expectations, I think it's critical that you have an idea of what will happen after surgery. And I can imagine you'd be very frustrated if the surgery doesn't meet your expectations. Right. And often people have unrealistic expectations. And so that's something we really have to sit down and spend time on. Surgery doesn't fix numbness most of the time. And that's a reality of it. Surgery doesn't fix weakness sometimes.
So you are telling the patient, for example, for this radiculopathy, which is that sharp shooting electric pain, that will likely go away, but you may have some residual numbness. And do you often in your practice, when you tell that to young patients who are the healthy patients, part of the healthy patient cohort, do they tell you that they don't want to have surgery because that they may
some people don't want, some people, what bothers them the most, for example, is the numbness.
Okay.
And the way that the pants feel touching their leg, it drives them crazy. And I understand that. But for example, some people, the pain, which was shooting down the leg, actually subsided with some Lyrica or medications. And now they're really mostly troubled by the weakness in the foot or the numbness or some other symptom, which has a much lower success rate with surgery. Okay. And so you just need to understand those things. We talk about those extensively when we go in. I want to make sure all of my patients know what they're signing up for. Okay. And you get a reasonable, so we talk about percentages, when we sit down, specific numbers that you can hang a hat on that said, this is my likelihood of improvement of leg pain, numbness, things. So I think as long as a patient understands what they're getting into, understands the probability of a certain outcome after an event, which is surgery, then people can make their own informed decision as to whether that's right for them. You did mention something else about some of these patients that you're seeing in the pre-op anesthesia clinics having, as well as, a few medical issues, which can affect our decisions as well. Some of these surgeries are more involved than a simple disc. So
can I bring it back to the second patient? So I've sent you a number of patients, and we talked about patient A, which was, our healthy patient, radiculopathy, nerve, let's do surgery, get the patient into rehab after, who will potentially do well post-surgery, doesn't have these medical conditions. But as we age, spinal stenosis, that's often in our aging population, so 50, 60, 70, 80 years old. I have one patient who I've sent you who, a very healthy 80-year-old. Actually, he's 85. Mm-hmm. I love seeing him in my clinic. Mm-hmm. Very positive, plays golf, but he has a typical symptomatology where he can't walk on the golf course as long. And walking every year has gotten a little bit harder and harder. Standing gets a little bit harder and harder. So he's at a point where he's retired. He gets so much joy from playing golf, but unfortunately he can't play as long. So he's went from playing 18 holes to now 9 holes to now just as many as he can get in a day.
Right.
But even though he is healthy, a very healthy 85-year-old, he does have all these medical conditions. So he does have diabetes, high blood pressure, although they're well controlled. He has a history of having a pacemaker, so something that kind of shocks his heart because he has an irregular heart rhythm. And unfortunately, or I should say fortunately, he wasn't a candidate for surgery, but he also gets some benefit from injections. And my goal with him is just to keep him moving and let him play golf as long as possible, because that's what really gives him happiness. So can we just talk about spinal stenosis and the other side of the spectrum? So we talked about a 35-year-old getting surgery. Let's talk about an 80-year-old going for surgery. And we see more and more spinal stenosis in our aging population. Yeah. And then how do you risk stratify this kind of patient for surgery? And how do you explain to them, some of the risks, the benefits, and what exactly are we doing so some of our viewers can know? I know this is a question where spine surgery can be so much more complex to this, but I just really want to have a basic understanding of what's kind of goal for spinal stenosis surgery, I should say.
So as you get older and your body becomes more complex medically, my goal is to do as little as possible to fix the problem,
right,
if it's absolutely necessary. And to me, surgery is last resort, because surgical risks are getting higher. And we're talking about high risk, high reward situations where, unfortunately, people can get hurt in surgery if you make the wrong decision or if something happens. So I think in these types of patients that have medical issues that are elderly, you need to absolutely exhaust conservative measures. And that means physiotherapy, massage, acupuncture, medications, as well as the minor procedures, interventional procedures, injections, ablations, epidurals, all of that. You need to be absolutely certain that this is not something you can manage anymore.
Okay.
And that you need a surgery to go forward.
So on that, what medical conditions or complex medical conditions as a surgeon are you worried about? And again, you also have the pre-anesthesia clinic where we also work in collaboration to optimize a patient before surgery. But in your 80-year-old patient with spinal stenosis, what are some of the complex conditions that would automatically almost disqualify a patient for you?
So it is that's a complex question. I think I worry about poorly controlled diabetes for infection rates. I worry about chronic heart and lung problems, congestive heart failure, things like that. But there's a concept in spine surgery called frailty, which is a composite of a lot of medical issues, which we can tell when you look at someone that someone's more frail. They have a lot of difficulty getting up out of a chair. They're very weak. They're deconditioned. All of the medical conditions that we talk about contribute to someone who's overall frail. And so it's a specific measure. We have many different scoring systems to actually measure that, but we have ways of testing how frail someone is really.
Okay.
And when someone's frailty score is high,
right,
then the probability of something bad happening is very high.
Okay. So even we have validated scoring systems for frailty, as you alluded to, but when you see them for the first time for assessment in your clinic, I'm sure you can delineate.
I have an idea just looking at you from experience.
And same in our interventional pain world, we always tell patients, you will do best with this injection or with this intervention if you can rehabilitate after.
Exactly.
And so I'm sure that's part of also your assessment post-procedure, is if this patient gets safely through surgery, will the patient be able to rehabilitate? Will the patient have enough social supports beyond what our healthcare system can provide them to actually get better and take care of themselves, etc. Right? And so that's really what makes sending our typical patients for spine surgery extremely complex. And so you obviously need to do a very comprehensive assessment of them.
Yeah, of course. Not everyone has 3 kids at home ready to care for them all day long, and the bank account to support 24/7 personal support workers, and sometimes the needs exceed.
So just as you said, spine surgery is an art, and we do more than just surgery and interventions. We actually have to take the care of the patient comprehensively. So just moving on, you alluded to a lot of this. You talked about optimizing a patient, and that's what I do in my life as well. I say this intervention will work for you, but it'll work better if you do this, this, and this all together, because it's really like a synchrony. It works like a synchrony together, right?
Yes.
And so one question I asked patients actually asked me, and I just want to talk about this with you, is I saw a spine surgeon. I saw 2 spine surgeons, and all they said is go to physio. You're not a surgical candidate. So what do you think about that?
I think sometimes, the surgeons are very busy, and maybe, they don't always spend the time necessary to fully articulate why someone might not be a candidate. But someone who's seen multiple surgeons and been told that, just go to physio or do some injections or whatever, you're not a candidate. There's probably something there that the surgeons understand but are not articulating. For example, maybe the surgery they would need is too high risk. Maybe the pathology that they're seeing on the MRI doesn't match fully the symptoms, and so they're hesitant to provide a surgery that's high risk
Right.
For example, there's many reasons why someone might see a surgeon and feel like they got sort of pushed off or sort of slighted and they're not fully considered. But sometimes the surgeon does understand. They just don't, maybe fully articulate it. I see it happen a lot. So, for example, like I might see a patient. I'd see patients every week that have severe spinal stenosis, but the symptoms they're experiencing don't match what I would expect. They're having, for example, shaking in the feet or coldness in one foot or something that doesn't really match the symptoms. And so I would ask myself, what is the likelihood that they would improve these atypical symptoms after I do this big high-risk surgery? It'd be low. And so while the patient does have a diagnosis of severe spinal stenosis, the symptoms aren't there that would get better after surgery, you see. So I might try and tell the patient, you're not a good candidate for surgery.
Right. And, we know spine surgeons are really busy. We know that in our landscape in Toronto, Ontario,
yeah,
there are waiting lists for surgery, and,
right.
and patients can get often frustrated. And so when I see them in my practice, I think really important, just to add on to that, is yes, physio is very important, rehabilitation is very important, but our patients have to understand that we're sending them for targeted physio.
Right.
And so that's a piece that we actually have to kind of overcome in
right.
our healthcare system, is like, I can send a patient to physio, but then the physiotherapist needs to have direction on what actually we want to do. So we need to do specific things for radiculopathy, specific things for spinal stenosis, specific things for facetogenic pain, right? Or, pain that originates from your facet joints. And so if we can do that, we can make a much larger magnitude of difference in our patients. And so I think part of the frustration that sometimes I see in patients is just go see physio with no actual direction. And hopefully we can close that loop together as a comprehensive pain team.
Right.
So Dr. Oitment, we've had a wonderful conversation. I think we've covered a lot for our patients and the people out there who are considering back pain. I'd like to just, pay people, we like summaries, I like summaries. Could you give us your 3 takeaways to a patient considering surgery or wondering if surgery is actually the right option for them?
Okay, so firstly, I think there's never harm in a discussion. So you can always talk. We can always meet. We can go through whether you might be a candidate or not.
Right.
We can talk about that. Second, there are risks. And in my opinion, surgery is always last resort. So whether you're 35 or 80, there are specifics in terms of what that surgery is and what the risks are. We can talk about that. But surgery should be last resort, and you should always exhaust these conservative measures. We talked about injections, physio, stuff like that. Third take home would be a lot of people get life-changing positive results from surgery, but you have to have reasonable expectations and you have to know what you're signing up for. And I think a lot of people don't.
Okay. So that's why they need expert consultation with you, or
of course,
speak with an expert surgeon who actually advocates for the patient.
Yeah.
Taking into consideration surgery and non-surgical options, right? If you're considering surgery or just confused about your back pain, send us your questions. We'll answer them in future episodes. Just remember, making an informed decision is the most important step. That's why we're here, to break it down all for you. Remember, this podcast is for educational purposes only. Speak to your doctor for personalized information. Next time, we'll be talking about non-surgical options for back pain relief. What really works? What's just hype? Don't miss it.